Well, I want to welcome everybody to this week's rendition of our Sagis Diagnostics Happy Hours. We're going to be continuing our our basic Dermpath series with a look at the big picture. I think another appropriate title for this lecture would be "Don't Lose the Forest for the Trees." And we're going to be looking at a series of cases to illustrate some fundamental principles relating to the interpretation of skin biopsy specimens. And this, is predominantly directed or geared towards the more junior residents, but in an effort to provide something for everyone, I've paired the cases illustrating some of these principles with histologic lookalikes so that we can have a relevant discussion of histologic differential diagnoses and hopefully add some interest for any of the more senior residents who are watching this or watching it at a later point in time. A few points to keep in mind. I think, I can't encourage you enough, especially the junior residents or the first years. In the beginning, almost everybody finds dermatopathology quite challenging. It really requires this skill set, which for most residents, unless you've been doing pathology in the interim, is rusty at best. You probably haven't thought too much about looking at microscopic images since medical school. So give yourself some grace, really be patient, do a lot of listening, you be prepared to do a lot of independent study, ask a lot of questions. And I can't underscore the fact that you need to really take the time to prepare for the conferences that are offered at your various academic institutions. And I think really in terms of thinking about the 3 years of dermatology residency as they pertain to Dermpath, the first 18 months, you're just kind of learning what's in the pantry, or if you want to use the restaurant analogy, what's on the menu. It's really in the second half of your residency that you really need to drill down on the more subtle nuances. So once you know kind of what you're responsible for, then you need to start considering the relative importance of diagnostic criteria. You pick up a textbook like Whedon's or like Elston's, they're really good, and they list all of these diagnostic criteria, but you have to kind of know which ones are most important, that the least common denominators, if you will. And those are the ones that you're going to want to go to the mat for. And then you also need to start considering lives of lesions. In other words, how the histology changes with time and with treatment. We spend a lot of time doing this clinically. Guttate psoriasis looks different than fully developed psoriasis, which looks different than treated psoriasis. Well, those changes are reflected histologically as well, too. And so you need to start thinking about those and thinking about the criteria that are used to diagnose diseases in the various stages of evolution. So where do you begin with histologic diagnosis of skin diseases? Well, at low power. And what you want to do is, starting at the lowest power possible, if you're using a microscope, that would be a 2.5 or a 4x objective. If you're looking at a digitized slide, zoom out and look at the whole slide. And you want, it sounds intuitive, but you want to make sure you count the number of pieces on the slide and make sure that you look at them. The medical legal literature is replete with cases in which a very skilled pathologist missed a diagnosis because they inadvertently forgot to look at a piece of tissue on the slide. So this admonition, this caveat bears repeating. And I can't tell you how many times on tests I've seen trainees, derm residents, who've spent an inordinate amount of time looking at the wrong piece of tissue on the slide. So just take some time to see what's there. Try to make note of the biopsy type. Why would you want to do that? Well, that tells you kind of what the clinician is seeing and what they were biopsying, okay? If you've got an epidermal tumor, something that's papillated or extending above the surface, you're likely to do a shave. If you've got a punch or an excision, chances are that the dermatologist was feeling something deep. And so that will give you an idea clinically of what compartment of the skin was involved. And then, of course, and I'm sure you've heard this in your conferences, you want to make note of the anatomic location. And Elston and a lot of textbooks of dermatopathology do a really good job kind of giving you a thumbnail sketch of regional skin anatomy and characteristic features of various locations. Spend some time looking at that, and really with very little effort and practice, you can get pretty doggone good at picking out regions of the body. This is important for a few reasons. One, obviously certain conditions have a predilection for certain anatomic portions of the body. And number two, if you haven't done it yet, there's going to come a time when either you put two specimens in one bottle or you transpose specimens. And if you have a good idea and working knowledge of regional anatomy, you can get yourself out of a lot of trouble that way. Likewise, try to make an assessment of the age of the patient. I mean, if you've got a biopsy with really enlarged sebaceous glands and a lot of solar elastosis, you're not dealing with a youngster. If none of those are present, the patient might be prepubescent. And again, we do that because certain conditions have a predilection for certain anatomic or for certain age groups. And so that can help you arrive at diagnosis. Because when you take your core examinations, there's usually no history. The stem just says the best diagnosis is, and then lists the choices. So once we've taken a look at scan and we've decided, we know how many pieces of tissue we're dealing with, we've made an assessment of biopsy type, anatomic location, and possibly age, then the next big question is, what box does the condition fit in? In other words, what process are we dealing with? And generally in dermatopathology, your biopsies will either be an inflammatory condition, a neoplastic condition, a cyst, a deposit, or a malformation or hamartoma. And obviously you can get some overlap here. I mean, you frequently neoplastic conditions have an associated inflammatory infiltrate, cyst cans, deposits can, but generally you can pitch it into one of these categories. And so we're going to spend the remainder of our time looking at paired conditions which illustrate each one of these classes of skin disease. Okay, and we're going to kind of start out with inflammatory dermatitis. Now, as a rule, inflammatory dermatoses in the skin are classified according to, and this is kind of common sense, the distribution and makeup of the infiltrate. Okay, so when you're looking at a skin biopsy, what compartment or what portion of the dermis is involved with the inflammatory cells, and what types of inflammatory cells are we dealing with? Also, in most classification schemes, the presence or absence of epidermal changes is very key as well. So this is just kind of how we approach inflammatory skin diseases. So I've chosen to illustrate an inflammatory skin disease with two conditions, one on the left, one on the right, characterized by epidermal hyperplasia or psoriasiform change. On the left, and we'll be discussing these at length, we've got an example of a subacute to chronic eczematous dermatitis, in this case, nummular eczema, and we're going to be comparing that on the right with psoriasis. So let's focus on our left piece here. We do have a punch biopsy. This particular punch biopsy is likely from the trunk or proximal extremity. We've got a relatively thick dermis, no subcutaneous tissue here, and a fairly low concentration of follicular and sebaceous elements. Here's a little hair follicle, but not near the density that we would expect to see on the head or neck. And there's no solar elastosis. I'm going to tilt the slide a little. If we look at the inflammatory infiltrate here, we can see that it's centered around vessels in the upper reticular dermis. So we've got this inflammatory infiltrate centered around the superficial vascular plexus. And you can see the epidermis is acanthotic or hyperplastic. Now, if we look at the quality of the hyperplasia, you can see it's somewhat irregular. So the rete, while elongated, are not uniformly elongated. So some are shorter or thicker than others. So we have kind of irregular epidermal hyperplasia. If we look at the cornithide layer, we see some compact orthokeratosis. We see a few retained nuclei, so we have some parakeratosis. And if you look, there's some serum, this pink material, admixed with the parakeratosis. So we have a little bit of scale crust. In addition, if you look in the underlying epidermis, we can see that we've got some subtle microscopic spongiosis or intercellular edema involving the mid-spinous layer. And we have a few Langerhans cell microabscesses here in the dermis. The papillary dermis is somewhat thickened here, and we have a moderately dense perivascular infiltrate, which was largely lymphocytic. There are a few histiocytes, and in looking at the sections last night and preparing for the conference, I think I found 1 or 2 eosinophils. So in sum, what we have here is a superficial perivascular dermatitis here with, the slide must be reloading. Sorry about that. Let me see if I can get it to reload here. Bit of a shutdown, yeah. Okay, so we've got a, in sum, a superficial perivascular infiltrate. We've got irregular epidermal hyperplasia, scale crust or serum admixed with parakeratosis in the stratum corneum, and some microscopic spongiosis. And this constellation of features is most characteristic of a subacute to chronic eczematous dermatitis. Excuse me. And we see these changes in lesions of contact dermatitis or nummular dermatitis. And probably in no group of inflammatory dermatoses is correlation, clinical correlation, as critical as it is with eczematous dermatitis. Okay, let's move on over and look at our other inflammatory condition. In this case, we're going to be looking at psoriasis, which is our kind of our prototypical or gold standard condition demonstrating epidermal hyperplasia. Now, this is a shave biopsy, and when we've got a superficial shave like this, determination of anatomic site becomes a little bit more difficult. The pattern of epidermal hyperplasia here is a little bit different as well too. You can see that the rete are bulbous and they're much more regular. The epidermal hyperplasia is more regular in psoriasis than it was in the prior example of chronic eczematous dermatitis. The rete are all kind of at the same length. If we look at the stratum corneum, we can see that we've got confluent parakeratosis, and there are collections of neutrophils present not only in the epidermis, but also in the foci of parakeratosis. But if we look at the stratum corneum here, we can see that this is dry stratum corneum. We don't have any serum admixed with the neutrophils. And so the scale crust here is dry. In this particular instance, the suprapapillary plates are markedly thinned. We've got dilated and tortuous vessels evident within the dermis, some closely approximating the undersurface of the epidermis. And if you look at the epidermis here, we have a suprabasilar mitotic figure. Okay, so these are features that are prototypic for a fully developed lesion of psoriasis. And undoubtedly, psoriasis is going to show up on your certification exams, either on the core or on the applied exam. So we've looked at two examples of psoriasiform dermatitis just to illustrate inflammatory dermatoses. Now, there are a number of algorithms that are out there to classify approach to inflammatory skin disease, and all of them are based on pattern analysis. And there's considerable overlap in these algorithms, and there's fortunately redundancy built into each. And if you pick up your favorite textbook of dermatopathology, Elston's or Whedon, you'll notice that they have a chapter on lichenoid dermatitis and a chapter on psoriasiform dermatitis and a chapter on blistering dermatitis. And these are the algorithms that I was talking about. And each classification of inflammatory skin disease has advantages and disadvantages. But I would encourage you to pick one, to practice it. You can even combine a couple of classes of inflammatory skin diseases if you want to, but you've got to become familiar with one and use it. And the same principle holds really for neoplastic skin diseases, because if you don't, especially after the first 18 months, start using a systematic approach to inflammatory skin disease, then what your brain is going to do is anytime you see a new slide or a new digital image, you're going to catalog it against every image that or every slide you've seen before. And it's a very slow, inefficient way to approach skin disease. So again, you're going to have to kind of craft an algorithm that's effective for you and one that's based on pattern analysis. Okay, let's go ahead and move on to neoplastic skin disease. When we have made the determination on scan that we're dealing with a tumor, an oma rather than an itis, what you want to do is make the determination initially as to whether you've got a benign process or a malignant one. And this really requires both low power scanning magnification and high power, because it's the combination of the architecture of the lesion and the cytology that really coupled together allow us to decide whether something's benign or malignant. But you definitely want to spend some time on scanning magnification, low power, assessing, again, the architecture of the tumor. Is it small? Is it superficial? Is it well circumscribed? Is it vertical? Is it horizontal? Does it have an infiltrative growth pattern? Can you see zones of necrosis? And these are kind of common sense features that all of us are familiar with that lean us towards either malignancy or malignancy. And then again, you'll want to go down on high power and look at the cytology. Is there a lot of nuclear pleomorphism, or the cells uniform? Is it mitotically active, or is it pretty bland looking? Is there necrosis, etc.? So benign or malignant is key. And then most classification schemes for neoplastic skin disease are predicated on deciding whether the tumor is epithelial, that is composed of epithelial structures, or if it's mesenchymal. If we're talking cutaneous tumors, almost all epithelial cutaneous neoplasms do demonstrate adnexal differentiation. So your key job is going to be deciding whether you've got a follicular tumor, a sebaceous tumor, an eccrine tumor, or an apocrine tumor. Obviously, mesenchymal neoplasms are a huge category, the second big category of neoplasms. And if you think about other structures in the skin that are not epithelial, you can begin to think about the classes of mosaical neoplasms. So in the skin, we have fibrohistiocytic cells, so we can get fibrohistiocytic tumors. There are nerves, so we can get neural tumors. There are vessels, we can get vascular tumors. There's fatty tissue, so we can get tumors composed of adipose. There's smooth muscles, so we can get smooth muscle tumors. There's hematolymphoid elements, so we can get hematolymphoid tumors. And we can't forget the class of melanocytic tumors as well, too. Melanocytes are derived from the neural crest. So some people will tuck those up into the epithelial category, not because the melanocytes are epithelial, but because of the close proximity of melanocytes to epidermal keratinocytes. Others will put them in the mosaical category. Doesn't really matter as long as you remember to include that in your classification scheme. So I've chosen to illustrate the approach to neoplastic skin diseases, or to illustrate neoplastic skin diseases, with two epithelial neoplasms. One benign on the left, a desmoplastic trichoepithelioma, and one malignant on the right. This is a microcystic adnexal carcinoma. And the more senior residents will recognize that these are both in what we call the Paisley tie differential, because in both instances, we have these narrow cords and strands of cells, collections of cells present within the dermis. So let's start with our benign neoplasm, and again, following the form and the approach that we advocate, we've got an incisional biopsy specimen here. It's inked, and this is from the head or neck. We've got a very high concentration of follicular and sebaceous elements. And even before we look at the tumor, we can go down here and see that there's solar elastotic material present within the dermis, which again is pretty characteristic of head or neck. Okay, we have this epithelial tumor, and if we look at the architecture of this tumor, we can see it's fairly superficial. It's present within the upper portions of the dermis, and it kind of has a horizontal growth pattern. Okay, it tends to be growing parallel to the dermal epidermal junction rather than diving down deep into the fat. It's not like super sharply circumscribed, but all in all, it's kind of got a benign silhouette. If we go down and take a look at the constituent cells of the neoplasm, we can see that we've got these narrow cords and strands of epithelial cells embedded within a very fibrotic stroma. So the stroma has kind of prominent collagen bundles and an increased number of fibroblasts. And there are a few horn cysts, or cystic structures containing keratin within this tumor. And in one of the pieces of tissue, may have been the top one or the bottom, some of these horn cysts had ruptured, and you can see foci of calcification within this tumor as well. And we back out again to low power. We can see that there's a little cup-shaped depression in the epidermis here. And one of the clinical characteristics of a desmoplastic trichoepithelioma, which is a type of follicular tumor, is that it frequently presents as a papular small plaque on the cheek, and it will frequently have a clinically evident central dell. And we're seeing that reflected histologically in these sections. Now let's go ahead and move on to our next slide. This is absolutely a huge piece of tissue. And sometimes with scan slides, digital slides, when people are starting out, it can be a little difficult to get an idea of size of the tissue. And that's because digitized slides can be scanned at very low power or at medium or high power. But we know this is a pretty deep biopsy. One, the epidermis is, way far away. It's fairly thin. And I'm going to get my pencil here. We've got this terminal hair follicle, which is embedded down in the subcutaneous tissue. And the dermis ends about right here. And we've got subcutaneous tissue, and below that, fascia. So this is an extremely deep biopsy. Given that fact, if we look at the silhouette of this tumor, this tumor wrote the book on an infiltrative growth pattern. I mean, this is not respecting the dermal subcutaneous tissue. This tumor is growing down deeply into and through the subcutaneous tissue, down into the fascia and to the base of the biopsy specimen. And we've got these big lymphoid aggregates down deep, indicating that the host doesn't particularly care for this tumor too much. If we take a look at the cells making up this tumor, again, we can see we've got epithelial cells, and they really have an appearance. The tumor aggregate's not too dissimilar from that of the desmoplastic trichoepithelioma. We've got these cords and strands of epithelial cells. There are a lot more of them, and they're more tightly packed and deeply infiltrated, but there's not a lot of cytologic atypia here. And that is a very characteristic feature of a microcystic adnexal carcinoma. Very infiltrative growth pattern, tendency to show perineural invasion, and yet cytologically very bland. Okay, so these are just two examples of an epithelial neoplasm. And again, I wanted to use them to kind of introduce you to the pattern of skin diseases and kind of the key things to assess when you're first starting to look at cutaneous neoplasms. We could give a whole talk on features that would allow you to determine what type of differentiation a neoplasm is showing, and perhaps we'll do that in the future. Our next big category of skin disease are cysts, and cysts, quite simply, are classified according to their lining. And so we're going to look at three of the most commonly encountered cysts here when we look at cysts. And in particular, we're going to look at cysts that have a lining that shows differentiation towards or is derived from different portions of the hair follicle. On the left, we have a follicular cyst of the infundibular side, the infundibular type, also commonly known in clinical practice as an EIC or epidermal inclusion cyst. Now, most EICs are derived from infundibular epithelium. They don't represent true implantation of the epidermis into the dermis. That does occur, in surgical sites and sometimes on volar sites. But most of these are believed to be derived from follicular infundibulum. As a result, they're lined by stratified squamous epithelium. There's interposition of a granular layer, and the keratin in the center of the cyst is this nice basket weave keratin. And you might say, well, this looks just like the epidermis, and you're right. Remember, the surface epidermis and the follicular infundibulum, the portion of the follicle from the surface epidermis down to the entry of the sebaceous gland into the follicle, is lined by stratified squamous epithelium, which keratinizes with interposition of a granular layer. Okay, and this is by far and away the most commonly encountered type of cyst that we see in the skin. Another common follicular cyst that we see is this one. This is a pilar cyst or trichoepithelial cyst, also known as a follicular cyst of the isthmus catagen type. Okay, and let's go on down and take a look at this cyst, the lining. And once again, we have stratified squamous epithelium. But if you notice, there's no granular layer here. The cells lining this type of cyst undergo very abrupt keratinization, and they produce this very tightly packed eosinophilic keratin. This is known as trichoepithelial keratinization, and it's the type of keratinization that one sees in the isthmus or middle portion of the hair follicle, that portion of the hair follicle that it extends from the site of attachment of the sebaceous duct down to the site of attachment of the erector pili muscle. And this is very characteristic appearance of a trichoepithelial cyst, also known as a pilar cyst. And a lot of times people, when they're first starting out, say, oh, I got to go down and look at the lining to see if there's a granular layer. But really, you don't have to do that because the keratin in these two structures these two types of cysts is entirely different. In an infundibular cyst or EIC, you're going to have this nice basket weave or shredded wheat type keratin. And in an isthmus catagen cyst or pilar cyst, you're going to have this more pink homogeneous keratin, which frequently will calcify. And sometimes you'll see a hybrid cyst. You'll see a cyst that has epithelium and in areas is producing basket weave keratin, and in other areas is demonstrating more trichoepithelial keratinization. So we do occasionally see hybrid cyst. The last condition that I'd like to look at here, more by way of presenting this as a unified concept, is a pilomatricoma. And if you look at a lot of textbooks of pilomatricoma, they'll classify pilomatricoma as a type of follicular tumor, and that's fine. I think a better way to think of a pilomatricoma is as a cyst which is lined by matrical epithelium. So remember, we've got the three portions of the hair follicle: the upper portion, the infundibulum; the middle portion, the isthmus; and then we have the inferior portion, which is lined by matrical epithelium. The surface epidermis shows keratinization with interposition of a granular layer and that basket weave keratin, which is what we see in infundibular cyst. We just talked about the type of keratinization we see in the follicular cyst of the isthmus catagen type. In a pilomatricoma or matrical cyst, and you really get an idea that these begin with cyst by looking down at the inferior portion. The cyst is lined by hair matrix cells. And as a result, we see a lining that has very basoid cells with a high nuclear to cytoplasmic ratio. Frequently, these are quite mitotically active, and they undergo keratinization in a fashion that basically recapitulates what one sees in the hair matrix. So these undergo abrupt keratinization. The cells lose their nuclei, and we get the formation of shadow cells or ghost cells. And this is how keratinization occurs within the hair cortex. So again, details, you can get those later, but cysts are classified according to their lining. Okay, what about deposits? That's our next big class of disorders. Well, deposits, of course, are classified according to the material that's present. You got to identify the deposit. And cutaneous deposits can be either exogenous or endogenous. And we'll take a look at a couple of examples. On the left, and there isn't much material here, I'm sorry, but this is Restylane, or injected hyaluronic acid. It was kind of iatrogenically introduced. And on the right, we have an endogenous deposit. We've got a gouty tovus. So let's start on the left. I'm not going to flip the slide. You can see we've got this punch biopsy, sebaceous glands from the face, and we've got skeletal muscle here in the dermis. And remember, the muscles of mimetic expression extend into the dermis, in the face. So if you see skeletal muscle up in the dermis, you're generally on the face. And you can see we've got this cystic space here. There's no epithelial lining, so this really isn't a cyst. And we've got this basophilic material that's kind of variable in size and shape, very uniform, and certainly not immunogenic, which is characteristic of Restylane. You wouldn't want to be injecting high hyaluronic acid into the skin if it was going to be inducing a brisk inflammatory response. So this is an example of Restylane or high hyaluronic acid. Elston's text has a really good appendix, the appendix 3, I think, and he illustrates the histologic features of all of the fillers, as well as suture material, aluminum chloride, triamcinolone. And you definitely, before you take your core exam, want to go over that, because anything that you as a dermatologist inject into the skin or place in the skin, the examiners are going to want you to be able to recognize that. Let's go ahead and move over to our other deposit. Here, I'm going to go ahead and flip the slide. And what we have here is a punch biopsy. And this was also from the trunk or proximal extremity. And in the dermis, you can see we've got these amorphous collections of kind of blue, gray to pink material. If we look up at the top portion of the material, we can see that around the periphery of some of this material, we've got these epithelioid histiocytes here, a few multinucleated. So, and these are arranged circumferentially around the material. So we've kind of got a very thin palisaded granuloma here. So this material is obviously inciting an inflammatory response. And if we zoom in and look at the material, we can see it's actually quite feathery. This has been likened to cotton candy. And you can see that in many areas there are needle-shaped clefts present. And this is a real nice example of a gouty tophus. Generally in gout, the uric crystals are dissolved with formalin fixation. So what one is left with is the matrix in which the crystals resided, and one tends to see needle-shaped clefts. So just wanted to show you a couple of different deposits. Again, diagnosis is predicated on recognizing the material, and keep in mind, deposits can be both endogenous or exogenous. And then finally, we'll close out with a look at hamartomas or malformations. Now, by definition, hamartomas is a non-cancerous collection of cells, kind of resembles a neoplasm of local tissue. And remember, from medical school, it's composed of an abnormal mixture of normal tissue and cells from an area in which the hamartoma is located. So we'll go ahead and look at a couple of hamartomas. We're going to be looking at an epidermal nevus on the left and comparing that with a nevus sebaceus on the right. Nevus sebaceous is also known as an organoid hamartoma. And if we take a look at the epidermal nevus, we can see that there is pronounced epidermal hyperplasia. The redi are elongated. They're very interconnected. There are a lot of horn cysts here and basket weave orthokeratosis. And this lesion has a very benign silhouette, kind of a flat bottom. And, the epidermal nevi look like seborrheic keratosis, with the exception of an inflammatory verrucous epidermal nevus. And generally, what happens to me when I see an epidermal nevus biopsy, I'm thinking, we see so many SEBs, I'm thinking SEB, and then you look down and that either the clinical impression is epidermal nevus, or more often than not, it's from a 12-year-old or an 8-year-old, somebody who's way too young to have a seborrheic keratosis. So keep in mind, there's a lot of histologic overlap between epidermal nevi and seborrheic keratosis. And we'll go ahead and compare and contrast this with, I'm going to tilt the slide here, with nevus sebaceous. Here we've got an excisional biopsy specimen. One can again see these terminal hair follicles embedded down in the fat. And what's interesting about nevus sebaceous, you have to kind of step back and take a look. If you take a look at this excisional biopsy specimen, you can see that there are hair follicles here embedded in the fat, and hair follicles over on the other side of the specimen embedded in the fat. But we've got a central area of alopecia. There are no terminal hair follicles here, and that's quite characteristic of a nevus sebaceous. If we look at the overlying epidermis, it looks quite a bit like the epidermal nevus. We've got papillomatosis and epidermal hyperplasia. But if we look along the dermal epidermal junction, especially in the areas over the alopecia, you can see that we've got a lot of very small and variably sized sebaceous lobules. Some of them open up directly onto the skin surface. And we've got some distorted follicular hair germs here. Nevus sebaceous is a hamartoma that involves not only the epidermis, but also adnexal structures. And over time, one will see development of a variety of adnexal tumors within a nevus sebaceous. Here we have an apocrine tumor, a syringocystic adenoma papilliferum arising in the nevus sebaceous. And frequently, one typically does not think of the scalp as being an apocrine-rich area. Frequently in the nevus sebaceous, one will see hamartomatous proliferation of apocrine glands as well. So this is just an example of a hamartoma here. So that's kind of our whirlwind approach of the big picture. And I meant to say at the start, if you have any questions at all about any of this material, please feel free to email us at education@sagisdx.com or send me an email directly, tdavis@sagisdx.com, or please feel free to call or text on my mobile number. We're always open to suggestions. If there's anything that you would like us to cover that we haven't, or anything that you might feel is beneficial, please be sure to let us know. And check out the digital library that we have, our YouTube library, and we're getting ready to redo our education page. So look for an announcement about that. I hope everybody has a great evening. Thank you very much.